今天我们两个 topic，那第一个 topic 的话是郭医师他会报告 modern fat grafting technique to the face and neck。郭医师请。
Okay. Good morning, Professor and everyone. I'm third-year resident Guo Xiaorui, and today I'm going to present the journal reading Modern Face Grafting Techniques to the Face and Neck, which was the CME article published on PRA's journal in last October. So let's start from the brief introduction. Facial aging can be characterized by soft tissue atrophy, redundant and toptic skin, and craniofacial skeletal remodeling. Volume deflation in the present facial retaining ligament results in noticeable folds and shadows. As the picture below, the orbital aperture increase, the eyelid opening decrease, and the lower lid descends into the cheek. Also, thinner upper lip, temporal wasting, deflation of the malar face pad, and the less defined jawline were noted as aging face. So, fat grafting has been used to treat facial deformity for over a century, and it has numerous applications outside of facial rejuvenation. And the Coleman technique continues to be widely practiced today, although minor modifications and innovations have been developed after then. So as the preoperative consultation, compartmentalizing the target areas using facial thirds help to guide the discussion with patients. And the donor size selection is based largely on the amount of fats needed and patient preference. The lower abdomen is more commonly used, and both the inner thigh and lower abdomen contain a higher density of adipose derived stem cells. And then the author outlines pairs of success learned from experience over years. So as 30 to 50% of fats may be lost with centrifugation, twice as much fat is often harvested to ensure adequate volume. And there was no notable difference between ultrasound and suction-assisted lipoaspiration on fat viability. But syringe or manual aspiration has proven to be more traumatic than liposuction-based harvest. And when the small volume graft is needed, telfa rolling is preferred. The harvest fat is placed in a sterilized centrifuge and spun at speeds less than 1,500 RPM for 2 to 3 minutes. Centrifugation separates the oil or ruptured fat cells in the upper layer, viable fat cell in the middle, and bottom aqueous layer of blood and local anesthesia. Higher density fat settles at the bottom following centrifugation and may have greater longevity compared to lower density fraction. The processed fat is transferred to 1 cc syringe for emulsification processing technique. And as modified Coleman approach for injection, small bore blunt cannulas are used for greater control and precision. An 18-gauge needle or V-shaped dissector Coleman cannula is ideal to release a scar or deep crease, such as in the glabellar crease or nasolabial fold. And subdermal or intradermal infiltration improves retites complexion and quality of the skin, whereas injection subcutaneously restores overall volume for more useful soft tissue draping. And the site-specific tips are included in this table as the three parts of face was introduced respectively. For the upper facial thirds, fat grafting to the forehead, temples, glabellar area, and eyebrows aim to address fat atrophy and gravitational descent of the tissues. When possible, injection sites should be hidden with creases or hairline. Injecting the corrugator and frontalis muscle with neurotoxin like Botox 2 weeks before fat grafting diminish the muscle movement to allow for graft survival. The video demonstrates the fat grafting at the lateral eyebrow and temple.
Infiltrating the lateral brow line. Care to avoid migration of the fat inferiorly. And also to the temple, which is slightly hollow. And we're in the subgaleal plane laterally on the periosteum. Lateral brow. Once you inject the fat, smooth it out. Make sure that your contour is good. Don't dislodge your orthoplasty stitches.
Okay. And the middle face thirds was regarded as the most anatomical complex and important in facial rejuvenation. As the face matures, the smooth transition of the lower eyelids and cheek is lost. Cheek fats recede and the orbital fats bulged superiorly, resulting in a bony orbital rim. And malar fat pads atrophy, hollowness of the infraorbital region, and laxity of the orbital retaining ligament all contribute to a tear trough deformity. So fat grafting in middle facial thirds includes periorbital region, malar fat grafting, which was divided into deep malar, deep nasolabial, middle superficial malar, and high lateral superficial malar. And also augmentation of the piriform aperture. So injecting the infraorbital area corrects hollowness and supports the infraorbital rim to elevate the lower eyelid. The video displays fat grafting in the tear trough in a periosteal plane.
So here's this processed fat. We're on periosteum. A small amount, 0.25 cc's. Does not need any more. You don't want to overdo it. Run through the septum, down to the periosteum. And of course, as patients gain weight with time, you have to be very careful, unlike with fillers, because you can't dissolve the fat. And this patient does not want to be overdone, so here we are with 0.25 cc's.
And also fat grafting of the lateral orbit region.
So here we're doing the lateral tear troughs. The same approach. Down on periosteum. Holding the finger inferiorly so the fat does not migrate. And then making sure that it's in the right position. Not overdoing it.
So as for lower facial thirds, fat grafting the lips achieve a fuller and healthier appearance. The lips are injected through access points at the oral commissure. In the white row area of deeper wrinkles, fat is placed subdermally and in a subcutaneous or premuscular plane. And beneath the vermilion, a submucosal injection is preferred for more protrusion, and injection along the wet-dry junction produce a more vertical lip. And furthermore, injecting the columellar labial angle creates a concave upper lip shape. And the mandibular septum is adherent to the anterior surface of the body of the mandible with platysma, and it separates the facial and jaw fats compartment from the neck fats. And fat grafting alone is optimal for a patient with thin skin and minimal jaws, but otherwise, some combination of mandibular septal release and SMAS elevation or platysmal application is recommended. And the useful, we're going to the neck region, and the useful neck was described as having a cervical ventral angle of 102 to 110 degrees, a well-defined jawline, subhyoid depression, and with a visible SCM border and thyroid cartilage. The change in the aging neck, including redundancy and laxity of skin, horizontal neck lines, and lipodystrophy, in addition to accompanied change in underlying bone and muscle. Treatment of the neck should take into consideration the submental, supraplatysmal, subplatysmal, and deep fat compartment, and also the understanding that subplatysmal fats may increase with aging. The access points may be placed within the mandibular shadow or exiting neck creases near target area of treatments. So micrograft and nanograft techniques harvest smaller fat cells and further emulsify the fat to inject with finer needle into very superficial areas. However, this technique do not address the large volume of pre-platysmal fat loss. So recently, lipotumescence was developed as the use of large volume infiltration of dilute fats. The video shows lipotumescent fat grafting to the neck.
Tumescent technique of choice and infiltration, large volume liposuction is performed of the patient's donor sites. And in this patient, that includes the inner thighs and lower abdomen, utilizing a water-based liposuction technique, such as hydrozolve or body jet. Once the desired volume has been achieved, the unwanted component is allowed to separate via gravity and discarded, and you are then left with dilute fat. This consists of small adipocytes and a slurry of stromal vascular fraction. Tumescent technique of choice, liposuction technique, rather than fully discarding the bottom layer of anesthetic and saline, part of the fluid is removed and the remainder is reintroduced via a Byron cannula in a dilute lipotumescent technique to the face and neck. It is our belief that lipotumescence not only adds fat precursors to the subcutaneous skin of the neck, but also improves the quality of the overlying skin. Note that we are taking care to ensure with our non-infiltrating hand that the cannula remains in the desired superficial area of the face and neck. We also note the presence of any superficial veins of the neck and avoid aggressive infiltration in that area.
Okay.
Liposuction.
So usually fat grafting or retidectomy is sufficient alone, but there are still some areas not addressed by retidectomy alone, including the perioral, temple, and deep fat compartment. Thus, the lift and fill retidectomy combines excision, resuspension, and volume augmentation by fat grafting. Although it prolongs operative time by at least 30 minutes and increased post-operative edema and recovery, but the powerful aesthetic result from combining retidectomy with facial and neck fat grafting cannot be ignored. And it can also be combined effectively and efficiently with eyelid and eyebrow procedures. So these are the pictures that combining fat grafting and other procedures, such as facelift and retidectomy. Finally, Some postoperative care should be noticed. Patients are instructed to sleep on their back with head elevation, and compression dressing with ice packing are used for fat Harvey sites. A soft diet is advised for 2 weeks after surgery for decreasing facial expression and chewing. And the most important thing is that patients should understand that it may take several months to have a natural appearance or to feel comfortable in public events. A previous meta-analysis of autologous fat grafting of facial rejuvenation did not report any major complications. The overall complication rate was 6%, with hematoma and ecchymosis being most common. The biggest drawback of facial fat grafting is the unpredictability of resorption. However, regrafting any sites was not suggested until at least 6 months after initial operation. And there are some recently innovation mentioned in this article, including nanofats, graft injecting through 27 gauge needle, and it has been used to deliver controlled, accurate, and precise fat partial volume for augmentation of the nasolabial groove, lips, orbits, nose, and chin. And another, additives to fat grafting, including fat preparation, stem cells, and platelet concentrates are recent attempts to improve fat survival. So to conclude this article, fat grafting to the face restore volume loss with agent and procedures reliable and sustainable results with minimal morbidity. And regardless of when the procedure is performed, it should be done after a thoughtful site-specific plan following a traumatic principles. And failing to restore a target area most often reflects an insufficient initial correction rather than resorption. So continued sharing of knowledge and refinements of the technique will make the process more reliable and will improve patient satisfaction with aesthetic results. So this is the end of my presentation. Thank you for your attention. And is there any comments or questions?
大家有没有什么问题，或者是如果有一些细节上面需要专家 comment 的，我们也可以请教张医师。部长。
我请教问题一下郭医师，他说或者陈晴可以帮忙回答，就是我们打了 FAT 以后，通常我们比如说打在脸上，我们说这个脂肪大概多久会 stable， 不要去按摩，不要去尽量少去动它，通常是大概是多久？
郭医师有没有答案？
这篇里面好像没有特别写到，不过他是说，就是术后6个月，就是尽量都，就是至少会需要3到6个月的时间，就是让它稳定，就是尽量不要再做其他的 procedure 这样子。然后张老师有没有其他的就是 comment 这样？
跟部长回答哈，这跟我们植皮类似。大概1到2个礼拜会有所谓的 revascularization， 那所以跟植皮一样，就是我们那个 tie over 有没有？拿量动还是会有点hematoma，通常1到2个礼拜，最多不超过3个礼拜，病人其实可以正常的洗脸，或者是正常的脸部的动作，这是可以被允许的，因为它的 vascularization 已经形成，只是新的 vascularization 有点 fragile， 就是 deep 按摩并不行。那通常我跟病人说 deep 按摩要3个月。那 Yoshimura 的 study 是说，如果你要讲到 survival rate， 真正的 stable 是1年，那大部分的 study 都是用半年，半年是可以被接受的，因为很多 paper 都是用半年。但是呢，如果你要真的跟人家好好的说服说你的 survival rate 真的是比别人好的话，你还是要用1年的 follow up。所以2件事，一个是 overall survival rate， 一个是 immobilization。那 immobilization 大概2到3个礼拜，那 overall survival rate 6到12个月。谢谢部长。
谢谢张医师、郭医师。请问大家还有没有什么样的问题跟 comment？ 他的这个procedure 里面有提到说同时间做不同的procedure， 比如说也做拉皮啦，或者是从脖子的地方再做抽脂。那如果我不知道主委跟新哥这边有没有什么样的comment， 对于说如果同时间做拉皮，然后又要做局部注射的话，那这个 procedure 上面有没有什么特别要注意的地方？然后先后顺序上面应该是怎么样子来安排？那我们请主委有没有什么样的 comment？
我大概开刀前做 tumor center 的 fat tumor center， 我倒没有这样做过。刚刚看了以后，我觉得或许是一个好办法。倒是开刀后，开刀中如果有一点 defect 或 depression， 我会做一点 graft。那现在大概偶尔打一下 fat， 但是不多。之后的一个 irregularity 我都 refer 给张医师的，张医师替我解决好几个 case， 就是觉得不满意一个高低不平的地方。不过反过来讲，我在看现在的 tendency 似乎是在开刀中能够补一点 fat， 我想这是好处。那开刀前的 tumor center 我没有经验，不过这样听起来，如果说身上有出很多 fat， 那来做一个 tumor center 的方式来打，或许是一个好方法。当做 tumor center 的方式补到它的 irregularity 部分，然后你在 dissection 之后拉完，能够留的留，这也是很好的方法。这是大家可以 try 的。
张医师有没有
我个人拉皮的经验不多啦，但是在少部分2、3个拉皮，我都会打 FAT， 因为这是我的强项。我发现说打完 FAT 真的是还不错啦。那 sequence 会先拉再打。那我有去看过威廉老师那个叫做Aston 的手术，那他都会同时打脂肪，那一样 sequence 是先拉皮再打脂肪。那也从中得中的灵感就是，他上下眼皮也会一起开，所以我目前如果会拉皮的话，我上下眼皮也都会一起开，这样子就几乎就是全脸都弄了。那最新的话，我还会甚至就是说，在那个脖子的地方打点肉毒放松，然后整个肉毒全部打。那刚刚有提到 upper face 的地方，有说那个 Botox injection improve survival rate。那我们在2000年有发表这一篇论文，就是说证明说 Botox 可以增加就是 immobilization， 就是那个脂肪能够比较安定。就像我们乳房打完了以后都要贴 shrink taping 嘛，那也是 immobilization 的一个 procedure。所以基本上我现在已经都是 combo 全部一起弄了。那最近我喜欢上一个就是打脂肪完了以后用 Acera 就是音波拉皮，它的结果比想象还好，每个病人都说变年轻好几岁，所以我倒是可以建议大家。那 音波拉比原本是很贵，要收大概6-7万，但是因为我们 IVG 码之下可以把能量调到最高，平常我们是用0.9焦耳，可以调到1.2焦耳，那你可以打少一点发数，少一点成本，就是多大概1万块的成本，但是可以让病人多年轻个5到10岁，我倒是觉得可以试试看。谢谢。
蛮珍贵的经验哦。那所以那个音波拉皮是推到开刀房来打。
是的，排除了万难，终于愿意让我们推了。
好，谢谢新哥，有机会可以看新哥来 demo 一下。好，那有没有其他的问题？如果还有一些细节上面的话，可以私底下再问张医师。
方便我做个小补充嘛？不好意思，
好
耽误大家一点时间。
不会。
那刚刚他有提到说有水刀，有超音波刀。那我目前比较用的是那个 Power Assist， 就是电动辅助。其实这3个比较就只有 donor side 的问题，所以 survival rate 这3个其实并没有明显差异。特别是微缩，大家想说那个超音波在那边把那个 fat embolization 以后再打 survival rate， 原本想说会比较低，但是后来的 study 跟那个赖兆义、黄荣儒的 study， 它的 survival rate 并不会低，所以微缩是可以使用的。那 lipotumorsen 他刚刚有秀一个那个罐子，那个从底部把那个水漏出来，那个罐子我们美容中心有，所以大家如果要的话，可以跟他们讲，那可以多加利用。那未来开刀房会买一个，那个不贵啊，那个就是一个罐子而已，所以未来我们开刀房也会有。那目前我们 nano fat 是有，那个 tit 叫 tulip， 那2.4、1.4这样子下去互推，各推40下。那推出来的 nano fat 里面只有 stem cell 没有活的脂肪，所以你可以打得很表浅，打到甚至 looping 都可以。那我会用在那个眼尾的这些 fine wrinkle， 如果打完脂肪它还有一点小细纹的话，你可以很表浅，用30号针就推得动了，表浅推1次就其实还不错。那 PRP 我们那个长庚诊所有，但是很贵，那个成本大概要接近1万5到2万，所以只是 improve survival rate， 它并没有其他的 extra 的话，其实我目前是不会使用这个。那倒是高黄凯目前的新的 exosome， 像聪哥就有跟他合作，我倒是觉得这个是 future。那已经证实 exosome 可以增加 survival rate 了。那它最主要是那个 ADS-C 的那个表面的那些exosome， 那它把它萃取出来，那里面含有各种物质。那 exosome 的好处是可以一体，因为它里面没有 cell 的东西，所以 exosome 可以一体使用，所以这应该是最近几年还会是最夯的东西，目前是这个样子。
谢谢张医师。
我请教一个问题现在越来越多的这些类似 trial 之类的，像刚刚说的 exosome 或者是各种我在想这些美容方面的手术，大家都是凭经验，到底有多少是evidence base 让我们可以遵循的地方？其实我是蛮有兴趣想知道，因为好的东西我们要学，可是如果只是经验，不见得有科学验证的话，其实是怪怪的。
跟部长回报那个，刚刚他在 review 的时候，第2张 slide 有讲到 modern technique 还是 common technique 还是目前最多人使用的。那第2个 list 就叫做 cell assisted lipotransfer， 这是有西木拉在2008年早期推出的。那它证实在乳房你加了那个所谓的 加了那个所谓的 ADSC 以后，它 survival rate 是可以好的。那这个仅次于乳房，为什么呢？因为乳房我们就是要大就是好嘛，我们一次就是能够打260，打300，尽量能多，因为病人一次就要多。但是很让人 disappoint， 就是一次就只有一个 cup。那所以呢，这在乳房的时候，你 survival rate 就很重要了。为什么？你差个5%，差个10%，就真的有差异。但是在脸部的话，其实还好，像辛利科曼跟那个 Rubin 有吗 ？Rubin 是那个什么亮安中的老师，他们做了一个 military 的 study， 就是在 temporal 的地方，这个地方，military 那些开过 craniotomy randomized 的 study， 就发现 cell assisted 的 lipotransfer 并没有 survival rate 的增加。所以在脸部，我的解读是脸部的 circulation 本来就很好了，那脸部 always 可以 overcorrection， 那你 survival rate improve 5%， 那依个人的经验，你加个5%，我觉得这是合理的，你就不用在那边搞一些那些什么 centrifugation 啊，然后又要把那个什么 ADSC 拿出来，甚至要 culture 啊，这些都不用。那脸部的话，就是我们大家熟悉的，就是自己平常大概像我的话，我会 overcorrection 10% 到20% 嘛，那这是已经习惯这么做了，就一直这样做，那达到最好的目标，我也不打算改变，因为改变的说 over 或 under 都是一个 harmful， 所以我倒是觉得就是说在脸部的话，不需要用这么多的辅助，但是呢，在乳房的话，真的是需要的，因为大家乳大就是好，大家一次都是要从 A 到 D 或 A 到 C， 但是目前的 technique 只能 A 到 B， 那 B 有 B-B+， 这就对病人有差了，所以为什么在乳房的时候，大家就会想加一些有的没有的，那在脸部我觉得还是好，甚至于就我刚刚讲的那个 study military study， 它是 show no difference， 所以我倒是觉得脸部就一般的 fat grafting 就可以了。谢谢部长。
很宝贵的知识啊。那接下来我们就请那个林医师，林医师的话，他要讲 tips and tricks for facial toxin injection with illustrated anatomy。好，林医师，请。林医师，您的麦克风可以。
主任早安，各位老师早安，大家有听到吗？
有，谢谢。
好，那我一样测试一下影片的部分。好，
这个会有声音吗？
有。
我们没有，刚刚还没有。这样影片的声音很小。
这样子有吗？
有比较好一点。
好。Good morning, dear professors and colleagues. I'm third-year resident Lin Dajun, presenting this CME article from PRS in 2022. Tips and tricks for facial toxin injection with illustrated anatomy. So the administration of neuromodulators, which is botulinum toxin type.
你没有回到你的 presentation 的 slide。
哦，好。
Yep.
这样子有了吗？
可以。
Okay.
So the administration of the neuromodulators, which is botulinum toxin A and other products, has increasing popularity in worldwide. And according to the statistic studies in American Societies of Plastic Surgeries, there's 7.7 million of Botox injections in 2019, which is increasing yearly. And compared to more invasive surgical procedures, it has more availability, high effective, and reduced cost and downtime. The benefit of the Botox injection. So by paralyzing the facial muscles, we can reshape the contour of the face and the skin quality. So there's a different type of attachment from facial muscle to the skin. In the hairy eyebrow regions, there's direct attachment from muscle directly to the skin. And in the forehead, there's indirect attachment, which with the frontalis muscles attached with the skin with the suprafrontalis fascia. And on other parts of the facial regions, there's mostly loose attachments with interplay between the muscle and the smooth system, and also the facial fat compartments. So as for the injection biomechanics, there's to achieve precise targeting treatments with the muscle we intended to treat. We can use different types of injections, including subdermal to affect the underlying muscle, or supraperiosteal to affect the overlying muscle. Also, if you inject at the facial soft tissue, we can diffuse equally and affect the muscle surrounding it. Also, the author reminds us to watch out for retrograde fluid fold, which is drug migrating through the injection canal and affecting muscles that is not intended to treat. So furthermore, the author has some keynotes as for the facial regions for neuromodulator treatments. First of all, the treatment of the horizontal frontal lines, which is caused by the frontalis muscle contraction. And there's sometimes the lines can be wavy, which means that the frontalis muscle was located more laterally. And also, when we decided how the length of the treatment, we should consider to note the length of the wavy lines, because it is where the frontalis muscle is. And it should be noted that the upper part of the forehead moves down caudally, and the lower part of the forehead moves cranially when the frontalis muscle contracts. And in between, there's the line of convergence, which is the C line. So as you can see in this motion study, you can see they marked the C line here, which the upper part contracts down and the lower part contracts cranially. And the ratio is about 4 to 6 of the upper part to the lower part. So when treating the forehead lines, we should consider the C line in it. Above the C line, supraperiosteal injection is suggested for a better efficacy. And as for below the C line, we should use subdermal injections and lower dosage to avoid the risk of eyebrow ptosis, which frontalis muscle is the only eyebrow elevator, so it should be kept in mind. As for the common adverse effects of the treatment of the frontalis muscle with neuromodulators, first of all is the eyebrow ptosis. Second is the lateral eyebrow hyperelevation, which is the Mephisto appearance. Mephisto is this Marvel comic character. So it can be avoided if the lateralization of the injection points is achieved. Also, there are some tips and tricks from the authors. If the lateral eyebrow hyperelevation occurs, a rescue injection can be used at the lateral eyebrow region. And also with patients with receding hairlines, the author suggests to inject at the posterior scalp as well. And with eyelid ptosis patients, the frontalis muscle acts as a function for eyelid elevation, so it should be assessed more carefully. So here is the okay, here is the video of it.
I injected. Particular patient, we're going to use a zigzag technique quite high up. We're going to give her 1 unit in each of these areas, and it's a deep injection on bone. I have cleansed the skin with chlorhexidine before I injected.
Okay, so zigzag, they inject zigzagly. Okay. On the second part of the facial regions, the author mentioned the vertical and horizontal glabellar lines, which is caused by 3 major muscles: the procerus muscles, the corrugator superciliis muscles, and the orbicularis oculis muscles. And for the procerus muscle and corrugator superciliis muscles, there's a clear defined bony origin, which can be used when during consideration of precise treatment for these muscles with supraperiosteal injections. As for the orbicularis oculis muscles, there's the bony contact only is at the orbital ring. So when treatment of these muscles, it should be injected at the subdermal region layer. All 3 of the muscles fuse with the skin at the level of the hairy eyeball. As you can see here, the procerus muscles and the corrugator superciliis muscle have direct contact to the bony region. And here is as well as the illustration. And as a result, the author promotes a technique of 3-point injection techniques, which is bony injections for the treatment of the procerus and corrugator superciliis muscle, as the 3 black points here in the illustration. And if the contraction of the orbicularis oculis muscles was noted when the patient was frowning, a subdermal injection for the orbicularis oculis muscle treatment is also suggested. And in comparison with the classic 5-point injection, the author thinks that this 3-point technique has less risk of collateral damage and less risk of eyelid ptosis. So this is the 5-point technique, and this is the author's 3-point techniques.
All right, when we're talking about the glabella, let's get you to frown. You can see the procerus and the corrugator muscles on each side. Relax. The dosing for a 5-point injection technique: 20 international units or 20 units of Botox and Xumin, 50 Spiewit units of Dysport. I begin, as always, cleansing our skin. Procerus, central injection, deep, 4 units, or 2.5 times that for Dysport. Good. Now we know that the medial corrugator is deep, so we're going to go deep. 4 units. The lateral corrugator is superficial, inserting into the skin. So we're going to give it 4 units right there. Then we're going to come to the other side. Again, I grab the corrugator, deep, 4 units.
Okay. And as for the adverse effects of these regions of treatment, it should be noted that we should reduce collateral damage, which could cause upper eyelid ptosis when levator palpebra superioris muscle was affected. And also there is risk of medial eyeball ptosis when the frontalis muscle was affected. So this is the authors using 3-point treatment and showing that the frontalis muscle was not affected after the treatment. So on the third region of treatment, the author said that the masseter hypertrophy and facial slimming region. And the masseter muscle has 2 separate muscle bellies, the deep belly and the superficial belly, which are separated by a strong intramuscular tendon. So, and the masseter muscle contributes predominantly to the shape of the face, and it can be easily palpated while clenching the teeth. And this intramuscular tendon can inhibit retrograde product distribution or limit the depth of product distribution. And the aim of the treatment for masseter neuromodulator treatment is to reduce volume and strength, which can be treated for facial slimming and also for the bruxism, which is teeth grinding for the patients. And however, there's also some adverse effects need to be noted, which is asymmetry or inability to smile when the risorius muscle was affected. And also, if the injections was too superficial and only treated at the superficial belly, the deep belly could push out through the weakened superficial belly, so causing the masseter to be more bulging. So the authors promotes a 1-point injection techniques, which target at the deep belly and at the maximal projection point when clenching. And he said that there's no significant difference compared to the multi-point injection. And there's some tips and tricks to be noted. The author said that we should assess the horizontal intermolar axis, and with the higher side should receive more buttocks. And also, it should be noted that by weakening the masseter, there's compensatory volume increase of the temporalis muscle. It can be also treated for temporal hollowing. And doses should be adjusted for the muscle volume, sex, and ethnicity. There's studies suggested that in Asian populations, it should be introduced in 3-point injections with 8 to 10 international units per injection. So firstly, the author showed the more traditional 5-point injection technique.
Masseter injections. I've identified the borders of the masseter, and you can see, clench please, and you can feel the anterior border right to here. And I've identified the masseter. Our superior margin is from the tragus to the oral commissure. Now we also want to think about where the risorius is, and that's one of the most unpredictable ones. We know that it affects and overlaps part of the masseter anteriorly, so we try to stay at least a centimeter behind the anterior edge of the masseter. Now, given the heads of the masseter, we want to use a 1-inch needle. This is the 5-point technique, and you can see the 5 points outlined here. And I use a 1-inch needle so I can get in a little bit deeper and get my product exactly where I'd like it to go. The amount of toxin we're using is 40 units in total. And we're going to separate that into 5 equal doses.
So the other technique is the 1-point technique, which is aiming at the most projected part.
On the side, we're going to use a 1-point injection technique. Again, the superior border from the tragus to the oral commissure. I've outlined where the masseter is. And clench, please. And you can actually see that my point, you can relax, is really at the point of maximum projection following contraction. The 1-point technique, again, using a 1-inch needle so we can get into the deeper head, is going to be straight down, and it's going to be 40 units directly into this area.
Okay, and as for the treatment for the chin, the shape of the trim is mainly determined by the mentalis muscle, and there's different shape in women and men. And the mentalis muscle is origin in the bony inferior to the labiomental sulcus, and the function is to elevate the chin and lever the lower lips. And there's irregularities of the skin noted when the mentalis muscle contract, which is called the chenulate. And the treatment for the mentalis muscle can achieve some goals, which has feminization of a facial appearance from a more square to heart-shaped chin, also to smoothen the labiomental sulcus, also to elongate the chin and improve the skin surface. And for male patients, you can support soft tissue fillers injection for masculinization procedures. There is also a first effect to be noted when treatment of the depressor labial inferior muscles was effective, and there can be asymmetric lip movement. And for the treatment of the mentalis muscle, different goals should be considered. For mentalis actively weakening, it should be treated with pre-periosteal injections. And for surface irregularity treatment, it should be treated with subdermal injections. And to avoid, we need to avoid DLI muscle affection. And if the muscle was affected, we should inject contralateral injection for a more symmetric lower lip position.
That I was ready. When we think about chin injections, we want to think about what it is that we're trying to achieve. We have the mentalis muscles that are close to the midline, and we have the labiomental sulcus. We want to think about elongating the chin. We're going to think about anywhere from 5 to 7 units in this area and allow it to capture both sides of the mentalis muscle. If we want to think about skin quality, contract your chin a bit. Thank you. We're going to think about, you can relax, we can think about more superficial injections in this area with about 1 to 3 units. And the bottom line is we want to say more central and medial, almost in the midline, as opposed to lateral, so it would not affect the depressor inferioris labia muscles. Let's begin. We're going to go with a 1-point injection technique. 1-point injection technique in the center, deep, and we're going to give 5 units in this area. Good.
Okay. As for the treatment for the jawline contouring, the contouring of the jawline was mostly in place with the platysma muscle. And the platysma muscle have a different connection with the facial muscle and the regions. In the lower part, it has direct connection with the DLI muscle and the modulus muscle. In the middle part, it connect with the smooth system, and then interplay with orbicularis oculis muscle and the zygomatic major muscle. So by antagonizing the platysma muscle with neuromodulators, we can elevate the total lateral face and also increase the mid face value. So the effect of the platysma muscle paralyzation, we can increase the difference in lateral projection between the mandible and the neck. Also, we can reduce the jaw by increased cranial pull. And there may be a special effect if we mistreat it with the depressor labii inferior muscle. As for the technique, we should inject 1 centimeter cranial to the mandibular line, and with 4 equally distant points, and with subfemoral injections. There are some tips and tricks to avoid the DAO. We can affect the DAO muscle if we want to treat the labiomandibular sulcus. And if there's platysmal bend noted during examinations, we can treat it in the same session as well.
So when we're thinking of improving the contour of the jawline, I've drawn out the mandibular border. You can feel it right here. And also clench your teeth and the pulling down of the bands laterally. We know that the platysma is a major depressor. And what we're going to do is we're going to treat this area with 2 units about 1 centimeter apart. And we try to inject approximately 1 centimeter cranial to the inferior border of the mandible. I also like to pinch the muscle itself and give it a few units again, following the same recipe inferiorly.
Okay. So this is the illustration of the effect of treatment of platysma muscle. So you can see that the mid-face volume increase and the lower face muscle volume decrease, and can achieve a better jawline contouring. So as for the follow-up, the onset of the effect of Botox or other neuromodulators is as early as 3 days, and the full appearance should be occurred at about 2 weeks. And we should remind the patient to monitor the muscular contractions for symmetry and intensity. And additional visits should be done with if there's any asymmetry was found. And we should document the outcomes with 2D or 3D imaging, and with both resting and muscle construction documentation. And if the patient received their frontalis muscle treatment too intense and report difficulty during upper eyelid movement, there can be used, a radio frequency treatment can be used for treat the selvedge. As for the take-home message of this article, there is new investigation methodology and 3D images in investigating the facial muscle and its interplay with our facial contouring and skin. So with this newly understanding of anatomy, we can introduce more precise treatment for the facial muscles with neuromodulators to increase precision and to decrease side effects and to have a better treatment outcomes. Thank you for your attention.
谢谢林医师。那我们是不是直接请张医师做一个summary 的 comment？ 金哥。
谢谢林医师。第一个问题是他的 masseter 40U 是两边的 muscle 还是一边？
应该是一边的。
OK， 好，那我们先从额头开始额头他有说 他有讲3个 plane 嘛，一个是subdermal， 一个是subcutaneous， 然后 superiostean。多年前我参加一个美国的会议，他们做了一个 randomized clinical trial， 发现就是说在 Frontalis 的部分，你打 subdermal 或是 Q 哈，其实没有差。所以呢，所以目前我 frontalis 的部分我都是 subdermal， 我就是打得很标签。为什么？因为这样子 ecchymosis 的几率会小一点。我们都知道这里很多血管嘛，那打到整个淤青的时候，甚至流血，病人的满意度会下降。所以打 Botox 是看自然。那目前的话，我是打4点，在眉毛跟额头的中间哈，然后平均的横的4点。那我看过黄药粒的打法，黄药粒是6点，但是大部分是一样的，因为我们照那个多年前，我们都每个人都有一张那个艾利根公司发的那个小书，那照着打都会变成那个 Mephisto appearance， 就眉毛会翘起来。我想多位同仁应该多多少少有这样的经验，像我早期都有，那我现在都没有。那另外一个重点就是在 corrugator 的时候，它是 5 point 嘛，那我现在是4点打法，就是中间那点没打以外，其他是一样的，其实效果是一样的。那为什么是这个打法呢？那另外一个比较宽的打法，你可以看到它都打到眉毛去哦。其实大部分 Mephisto appearance 也是这样造成的，因为你中间的眉毛被你 polarize， 但是 lateral 的眉毛还可以动哦，就那个后眉毛翘起来哦，病人其实会骂的蛮严重的。虽然你再补救一点肉毒是可以的，但是还是会被骂的哈。那接下来就是在讲到那个马塞特最早是我们感谢余宗志的 study 哈，他在2007年发表嘛哈，他发表就是说那时候是使用 Despo 的情况下哈，在120U 6 point injection 的情况下哈，马塞特的 volume 减少30%，其他的 muscle 的 volume 并没有改变。那也让我们知道，就是说，其实 muscle atrophy 那篇的报告就是最满意的是在3个月到6个月，那6个月以后会慢慢的恢复。那之后的 study 呢，像韩国的 study 是说一边10U、20U、30U 比较，10U 不够，20U、30U no difference， 所以他的建议是20到30U， 然后我取一个中间数字，所以我个人目前是24单位。那我们也接受艾利根的那个 multiple center clinical trial 哈，那是在大概5年前。那它比较24、48、96U 哈下去比较。那当我们已经到96U 的时候，其实 muscle atrophy 只增加 5%。所以我不知道作者最末为什么是用40U， 其实40U 跟30U 理论上来讲的话 muscle atrophy 只增加大概2-3%， 但是你要增加2倍的剂量，其实是我们中文讲就是比较划不来了哈 ，CP 值比较低了哈，所以目前还是建议20到30U。那我们从6 point injection 到5 point injection， 那目前我是3 point injection， 这是该来了哈，就是那个耳垂到嘴角嘛哈，那耳垂到嘴角从5 point 那是旧的，现在已经是3 point， 就是平均分担，但是1 point 是未来。那个陈仁忠医师一直在 challenge 我说1 point injection 就够哈，因为它本身 Botox 就会 diffusion 嘛，它会左右扩散嘛，所以其实1个 point injection 是够的，但是我现在还没那个 guts 哈，下去只做一个 point 哦，我还是很习惯打3点哦，或许某一天我就会打到1点的哈。那 Jawline contouring Mentalis muscle 我想跟各位比较有关的哈，在座的各位，那像 bimaxillary protrusion 哈，或者小下巴的人，因为嘴巴关不紧，所以他们 Mentalis strain 都非常的严重哈，就像这个图那个中间这样凸一团哦。那在手术当中哈，因为我们是全麻嘛，所以1 point 跟4 point 就没差哦，我是4 point， 然后就是那个最凸的地方哦，打4点。 那每点2U 这样子就够了，总共8U。8U 的话，大概增加成本是大概在640元台币。但是我每个都打，所以他们就会觉得说他下巴的改善。那我倒是建议各位就打个几次以后，这个 irregularity 可以永久，就几乎就会改善，因为他之后嘴巴闭得好的时候，他就不用再用那么多的那个 Frontalis muscle 了。那另外一个跟我们息息相关的是 Jawline contouring 那我跟他打法不一样，他是打在1 centimeter above， 我是1 centimeter below。那其实它会 diffusion， 所以其实两种没有差，但是1 centimeter below 这是那个所谓的比较学术的概念，因为神经就在他打的那附近嘛。那你当然不想了，但是你一针戳进神经以后，整个神经 paralyze 的话，会变成半边的嘴角的 symmetry。虽然没有被这样 report 过，但是我们还是要尽量小心。所以我还是1 centimeter below， 就是它大概画白线的那个地方。那好处是什么？像我现在打脂肪尤其是脸颊凹陷的地方，我打完脂肪以后，它有一个向上拉的力量嘛。那我下面放松了以后其实病人会明显的变年轻那个 jaw 会稍微的改善。那最主要他有讲，就是说我们那个 mandible 的那个跟这个 neck 的这个区分会变明显，所以这条线变漂亮了以后，女孩子都蛮喜欢的那像我现在打那个马赛特的时候，我会建议各位下面再打个4点那个Jawline出来以后，马赛特变小了以后满意度会更高这就是我们跟外面的区别了，就是通常别人打完来跟你打，你做一点点的小小的改善，他会觉得他讲不出所以然，但是他会说你打的比较好看他就会慢慢的就会变成你永久的病人那通常他们会6个月到9个月会来打一次。那之前的 study 是马赛特连续打3次以后，1年以后他 atrophy 还有12%所以只要他不咬硬的会永久。那还有另外一个很特殊的发现是在facial asymmetry 的病人，因为他长期都只用一边的牙齿在咬嘛，所以他其实你仔细看 CT， 我们现在都有封闭 CT， 一边的马赛特会比较大。所以在做完 OGS 的时候，我会建议一边打24单位的肉毒，让那个肌肉恢复正常。那当病人脸消的时候，大概全部脸消大概3个月吧。那3个月后，他会觉得两边的对称度会改善很多，最主要是那个 muscle 也变小了。那之前有病人打过1次，有病人打过2次，后来就再也没回来，因为他咬合变好了以后你会教他说如何用2边平均咬，他就再也不是只有一边在咬，所以他那个马赛特单边的 hypertrophy 就会改善，那脸部对称性会更好。所以我倒是建议就是 facial asymmetry 你看 CT 一边的马赛特大于另外一边的时候可以打一点点。谢谢。
谢谢张医师。聪哥有没有什么 comment？ 聪哥？
没有。
聪哥觉得injection 1点就可以了的立论点。
其实当然我是比较懒的，另外我是觉得 muscle， 因为马赛特 muscle 本身它应该是中间你一咬的话，中间鼓起来的地方厚度比较厚嘛，
是
旁边比较薄。那我就想象说，那你打下去厚度厚的地方，当然消的比较，如果说它剂量比较高，消的比较多也是合理。因为有时候我们打在比较外侧一点，也会造成周遭的 tissue 有点轻渐 depression， 所以从这个例点，我就觉得偷懒打1点应该是可以了。
是。好，谢谢聪哥。那大家还有没有什么想要有问题或者是有要讨论的？如果没有的话，那我们就有一些可以私底下再请教2位 那今天的 morning meeting 就到这里，谢谢大家。